Hello everyone, it's Dr. Locklear here, and we are continuing our focus on the concept of perfusion. This recording will focus on Exemplar 16J, which is Peripheral Vascular Disease, or PVD. So what causes PVD? How does it occur? And in this particular exemplar, we are going to look at the difference between arteriosclerosis versus atherosclerosis. And in a previous recording, I had mentioned that you needed to know the difference between the two, and so we're going to come back and look at that again. What is the etiology? How does peripheral vascular disease occur? What are the risk factors? Can it be prevented? Are there things that we can do to actually stop this process? As a nurse, what will you see with your clinical manifestations of PVD? And who do we collaborate care with the interdisciplinary team? What are the diagnostic tests that we use, and what are the labs that we look at? How does this affect people across the lifespan? You usually see this in people of older age, but it does depend on severity of your diabetes, or so it can occur in younger ages as well, because we know diabetes affects circulation. And then, of course, the nursing process. What are we going to observe? What are we going to ask the patient? What's the physical assessment? What are you looking for? And then what are our interventions when we start to implement care? And then, of course, don't ever forget evaluation. We need to make sure that our care actually worked, or if it didn't, we regroup and develop another care plan. So let's get started. So what is our overview? Peripheral vascular disease, or PVD, is also called peripheral artery disease. Refers to a category of circulation disorders that may occur when pathologic changes such as arteriosclerosis and atherosclerosis impair blood supply to the peripheral tissues, particularly the lower extremities. And you see in the picture here a person with PVD, and they've got poor circulation, so now they're having skin breakdown and open wounds because their tissue is dying. Remember, we've got to have oxygenated blood to keep our tissues alive. Arteriosclerosis, the most common disorder of the arterial system, includes wall thickening and reduced wall elasticity, leading to calcifications within the vessels. A subcategory of this is atherosclerosis, where you have fat and fibrin accumulation, which obstructs and hardens the arteries. And then we have chronic venous insufficiency, is the lack of adequate venous flow occurring over an extended period of time. The underlying cause occurs in the leg veins, where valve leakage or a blockage impedes blood flow back to the heart. With the resultant blood pooling, stasis occurs and can result in DVT. Peripheral vascular disease primarily affects older adults, with greater prevalence rates seen in adults over age 80, because we know with just normal aging, our vessels lose elasticity, and they may thin and become smaller in diameter. And then according to, kidney disease or diabetes, that determines if it gets worse as well, or heart disease, coronary artery disease. African American patients are at increased risk, whereas those of Hispanic origin seem to have similar to slightly higher rates of PVD when compared to non-Hispanic whites. Overall, approximately 8.5 million people in the United States are estimated to have PVD, and that's just the United States. That's not worldwide, and that's a lot of people. So this is a very prevalent problem. What is the patho and the etiology? The lesions of atherosclerosis develop in two layers of the arteries, the intima and media. When thrombosis develop, they occur more frequently in the lower extremities versus the upper extremities, because it has further to travel. In the abdominal aorta, atherosclerosis develops as plaque that erodes the vessel wall, resulting in aneurysms. And when these aneurysms rupture in the abdominal wall, death is usually very intimate. Very few people survive an abdominal aneurysm. It's very deadly. In the lower extremities, when plaque develops, the vessel progressively obstructs, reducing blood flow and leading to tissue hypoxia. So again, the tissue is starving of oxygen. In response to gradual obstruction, collateral circulation forms, but it is inadequate at times of increased metabolic demand. So you still got some circulation. It might be okay when you're at rest, but as the demand increases for oxygen, like when on exertion or things like that, it's not going to be enough to supply. Symptoms emerge when 60% of venous flow is interrupted. And then you have venous stasis, is the stagnation of blood in the leg leading to CVI. And again, that's chronic venous insufficiency due to increased venous pressures. As venous pressures increase, the arterial circulation is also impaired, reducing oxygen delivery to tissues. Metabolic waste products also accumulate. Lower extremity skin darkens due to RBC breakdown in the congestive tissue. The reduction of capillary function results in skin atrophy and necrosis of subcutaneous fat, ultimately resulting in stasis ulcer formation. As the stasis ulcer worsens, ineffective inflammatory and immune responses increase risk for infection. What are the risk factors? Risk factors for PVD are consistent with those for other cardiovascular diseases. These include smoking, hypertension, elevated cholesterol, diabetes, family history, obesity, and lack of physical activity. Other factors such as prolonged standing or sitting can also lead to PVD due to deep vein valve damage. And our vessels do have valves, and when they don't work properly, then the blood is not flowing through as appropriate as it should. And here on this slide, you can see there's other things listed. I found this little chart, and so some other things are alcoholism, your occupation, elevated BMI, which relates to obesity, decreased kidney function, estrogen and oral contraceptives. These were some extra things that I found. So what is the prevention? Because PVD arises primarily from atherosclerosis and other disorders that impair cardiovascular function, prevention focuses on preventing these processes and includes maintaining a healthy lifestyle, maintaining a healthy weight, eating a healthy diet, and exercising regularly and following treatment regimens for chronic illnesses. Individuals who are at risk may be screened for PVD by their healthcare provider using an ankle brachial index. Medications for claudication, and we're going to talk about claudication, in addition to lifestyle choices, may also help slow or even reverse the progress of PVD symptoms. These include high blood pressure medications, getting your cholesterol down with cholesterol medications, and also drugs to prevent blood clots. So your anticoagulants such as Coumadin, just an aspirin a day sometimes is all you need. So what are the clinical manifestations? What will we see? PVD can result in the intermittent claudication. So what in the world does that mean? Where cramping in the calves or thighs occurs with activity. It is relieved with rest. However, rest pain reflects burning even with inactivity and increase with leg elevation. Numbness and tingling accompany rest pain. And I got you a little chart here about intermittent claudication. So it's a reproducible discomfort of a defined group of muscles that is induced by exercise and relieved with rest. So in other words, it's supply versus demand. So if I'm exercising or something and my circulation's not good, I may have this claudication experience because it can't get enough blood supply there according to the demand of what I'm doing when I'm exercising. In PVD, peripheral pulses are usually diminished or absent. If obstruction exists in the arterial vessels, a bruit can be heard over the large arteries, and this is like a whooshing sound. Skin coloration of the legs changes with position. They become dark red or dependent rubor, and that's how we would describe the color. You would list it as rubor. It's a reddish color. And they can be pale with elevation. Lower extremity skin is thin, shiny, and hairless because the hair's not going to grow because it's not getting enough oxygen. And the toenails are thickened. Ulceration may be present as well as edema. And you have a picture on page 1341 that shows a chronic venous insufficiency ulcer. Look at the discoloration around the patient's ankle and what we call a stasis ulcer. In other words, the tissue is dying and a wound develops. And so you have what's called a stasis ulcer there. In CVI, which is your chronic venous insufficiency, recurrent stasis ulcers develop at the medial and anterior aspects of the ankle. Due to impaired circulation, poor healing results and the surrounding tissue is discolored. And you have a chart below, chart 1627 compares venous and arterial ulceration. So let's look at that. So if it's arterial, it'll be toes, feet, and the shin. Deep pale, normal to atrophic, pallor on elevation, rubor on dependency. It'll feel cool. You'll have absent or mild edema. Pain is usually severe with intermittent claudication, and you can have pain at rest. Gangrene may occur, and pulses are decreased or absent. With venous ulcers, it's over medial or anterior ankle. Superficial and pink is the color. Brown discoloration, stasis dermatitis, which is a type of skin. The skin is affected, and it may look dry and itchy. Cyanosis, so you got some color changes. Skin temperature is usually normal. Edema may be significant. Pain usually mild and aching pain. Gangrene usually doesn't occur, and pulses are usually normal with venous. So collaboration. So what do we do? What are we? Who are we going to collaborate with to help prevent this or improve it? Management of PVD includes preventive measures to reduce atherosclerosis development to sustain tissue perfusion. Symptom management, circulatory support, and skin injury prevention or healing are essential in the care of the patient with PVD. To determine the diagnosis of CVI, which is chronic venous insufficiency, a history and physical is required. Medical history is obtained to assess for risk factors. There are no gold standard diagnostic tests for CVI. Treatment is conservative. Well, let me go back. No gold standard, but sometimes just looking at the patient's body part, you can tell there's an issue going on with circulation. It's very obvious. Treatment is conservative, including instructions to lessen edema, reduce prolonged standing or sitting, and correct use of support hosiery during the day. And I gave you a picture here of wearing compression stockings, and you need some that go all the way up to just about your knees, so they cover the calf, and they need to be a firm stocking. I know when I go to clinical with you all, I wear my compression stockings. It really helps my legs a lot. And they don't ache and hurt as bad when I've been on my feet all day long. Nocturnal leg elevation is encouraged, so at night. When stasis dermatitis is present, treatment depends on the extent of the disorder. With weeping dermatitis, wet compresses of boric acid, buffered aluminum triacetate, which is a boro solution, or Domboro, and it's been around for a long time, or isotonic saline solution are used 4 times per day for 1 hour, followed by topical corticosteroid cream. Treatment of stasis ulcers also includes use of an Una boot, cotton compression bandage impregnated by zinc oxide paste, and you wrap it around the patient's leg and it forms like a boot, and it's a protective type of bandage that you can leave on there for several days, and they work very effectively. I've used those many times. Or you can use a conforming stretch gauze bandage, or that's what the Una boot is. It's a conforming stretch gauze bandage. These treatments are applied as strips and allowed to dry to a semi-rigid boot with replacement every 1 to 2 weeks. Time to replacement depends on the ulcer drainage, and it will drain through the Una boot. Skin graft surgery may be indicated for large ulcers. So a lot of times, they can just try different things, but the Una boots work really good. I've actually seen that in practice. Diagnosis of PVD is made by medical history review and physical exam. Extent of disease can be determined using diagnostic tests, and some of these include segmental pressure measurements. These are listed on page 1241. This is where BP between arm and legs are compared. In PVD, the leg BP may be lower than the arm. This test uses blood pressure cuffs and a Doppler device. Stress testing can indicate PVD where ankle pressure declines with exercise. This serves to measure functional limitation. Doppler ultrasound can indicate PVD when the ultrasound waveform is flattened compared to normal waveforms. The underlying mechanism uses sound waves to evaluate blood flow. The duplex Doppler ultrasound extends DUS with ultrasonic imaging. This test provides images of the affected vessels, and color images are available, so it makes it more clear to see. Transcutaneous oximetry evaluates tissue oxygenation, and angiography or MR or magnetic resonance angiography evaluates the location and the extent of the arterial obstruction and is a pre-procedure test to revascularization. Fluoroscopic visualization is done using a contrast medium, whereas MRI does not require contrast. So the MRI can show more clearly where the occluded vessels are. Pharmacological therapy, and that's on the previous slide. Peripheral vascular disease is not as effectively treated using drugs as other cardiac diseases. Drug therapy focuses on platelet aggregation inhibition using aspirin or the antiplatelet drug clopidogrel, cilostazol, a platelet inhibitor with vasodilator properties, increases blood flow to the extremity, thereby reducing claudication. Pentoxifylline increases microcirculation by decreasing blood viscosity, so it helps make the blood less thick, and increasing RBC flexibility. And then, so there's not a lot of drugs that they use. They do use some. We used to give a drug, and it's the clopidogrel, persantine, and that was used for circulation issues in the lower extremities. Non-pharmacologic therapy. Treatment for PVD beyond medications focuses on preventing measures. Smoking cessation is vital for the treatment of PVD. Nicotine, a potent vasoconstrictor, promotes atherosclerosis. Skin care, focusing on foot care, prevents ulceration and infection. So you want to pat the skin dry. You don't use a lot of soap, and you make sure that the lower extremities are rinsed well, and there's no soap to dry out the skin, which can lead to cracks, which can lead to wounds. And now if you've got poor circulation, those are harder to heal, and you dry in between each toe as well. So you want to focus on good foot care. Regular lower extremity exercise such as walking promotes vascular tone and circulation. When claudication is present, rest is recommended. Control of comorbidities such as diabetes, hypertension, and elevated cholesterol and obesity is also recommended. So you've got to get that weight under control, and that's not easy to do. In PVD, indications for surgical revascularization include progressive, severe, or disabling symptoms such as ADL impairment or pre-gangrenous or gangrenous lesions. Endarterectomy, and I showed you a picture of that on a previous recording. Endarterectomy removes occlusive plaque. Bypass grafting establishes blood flow distal to the significant blockage using knitted Dacron tubing. Better outcomes are seen with surgical procedures versus non-surgical intervention, but operative complications must be considered to determine best treatment. Other vascular interventions include stent placement or atherectomy using balloon angioplasty and mechanical laser or thermal plaque or occlusion removal. Stent or mesh framework insertion is common to maintain vascular patency. More than 80% of iliac and femoral popliteal PTCA result in good blood flow and symptom relief. So here's a picture of an endarterectomy, like in the vessel in the neck, and they go in and they take out the plaque, or they can do a bypass graft on it as well. Nursing process. Before we look at nursing process, I want you to look on page 1342, and it says patient teaching foot and leg care for the patient with peripheral atherosclerosis. Keep legs and feet clean and dry and comfortable. Wash legs and feet daily in warm water using mild soap. Pat dry using a soft towel. Be sure to dry between the toes, as I just said. Apply moisturizing cream to prevent drying, but don't put a whole lot on there because moisture does hold bacteria, especially for the diabetics. Use powder on the feet and between the toes to help absorb the moisture. And it's really good to use powder that has cornstarch in it because it does absorb moisture very well, and it keeps it from being moist in that area too. Buy shoes in the afternoon when feet are the largest. Never buy shoes that are uncomfortable. Toes should not touch the tip of the shoe. Wear a clean pair of cotton socks each day because cotton breathes better and it don't retain moisture as bad as nylon does. Prevent accidents and injuries to the feet. Always wear shoes or slippers when getting out of bed. Do not go barefoot. Inspect legs and feet daily. Use a mirror to examine backs of legs and bottoms of feet. Have a professional foot care provider, which is a podiatrist, trim toenails and care for corns, calluses, ingrown toenails, and athlete's foot. Always check the temperature of the water before stepping into a tub because people with PVD, they do lose feeling and sensation, and they can't always tell how hot the water is, which can be very detrimental to the skin. It can burn and cause second and third degree burns. Do not let the legs or tops of the feet get sunburned. Report leg or foot problems, increased pain, cuts, bruises, blistering, redness, or open areas to the healthcare provider. Improve blood supply to the legs and feet. Do not cross legs. Do not wear garters or knee-high stockings. Do not swim or wade in cold water. And all these are great things that you all could use on your concept maps if you're caring for a person that's got some circulatory problems. These are excellent. So what is our nursing process? The role of the nurse in treatment and management of peripheral vascular disease focuses on patient teaching regarding healthy lifestyle habits. Foremost is smoking cessation. Teaching includes physiologic action of nicotine, a potent vasoconstrictor, and importance of a nicotine cessation plan with a future quit date. So when are you going to quit? Other educational topics include recommending dietary changes for healthy weight and promoting regular exercise. In patients with cardiovascular risk, regular screening should also be encouraged. PVD education concepts include elevate legs while resting and during sleep. Walk as much as possible and avoid sitting or standing for long periods of time. When sitting, do not cross the legs or allow pressure on the back of the knees. Do not wear anything that pinches the legs, knee-high hose. Wear elastic hose or compression stockings as prescribed, putting them on after legs have been elevated. The elastic hose should be tighter over the feet than at the top of the leg. Safety alert. Teach patients who wear elastic hose or compression stockings to be sure the tops of the hose do not cut into their legs. This can cut off the circulation to the lower extremities, compounding the damage from PVD. Keep the skin on the feet and legs clean, soft, and dry. And again, follow the guidelines in that teaching box, which are excellent. That's probably one of the best that I've seen. I mean, it was very clear cut to the point. So what is our nursing assessment? Observation and interview. Observe for signs of pain associated with PVD, such as limping or guarding. Observe for edema, skin discoloration, shiny skin, and other related signs of PVD or venous ulcers. During the patient interview, assess for complaints of pain, its relationship to exercise or rest, timing associated symptoms and relief measures, history of CAD, PVD, hyperlipidemia, hypertension or diabetes, current medications, do you smoke, how long have you smoked, and there's something called pack years, and your pack years determines, depending on how many years you smoke, can help determine the rate of damage that you have. And what is your diet and activity patterns? So when we do the physical exam, what looking for? We want to analyze the vital signs. Do we have peripheral pulses? What's the quality and strength? Are they the same? Is the left different than the right, or the right different than the left? Sometimes you have PVD in just one extremity. Do you have equality across all extremities? Is capillary refill good? An evaluation of skin color, temperature, and hair distribution, because hair will not grow if it has poor oxygen supply. Nursing diagnoses, inadequate peripheral tissue perfusion, chronic pain, compromised skin integrity, and inability to tolerate activity. And these are just a few. Problems, disturbed body image, because it looks, if you've ever seen anybody with rubor on their lower extremities, it looks odd, and people are very conscious of that. Potential for infection because they have open wounds. Their mobility is compromised, so again, that can lead to skin breakdown and wounds and infection, and maybe eventually sepsis. Planning, stop smoking, learn appropriate foot and wound care. So you teach the patient how to do it and have them return demonstration. And they may need to go to a smoking cessation class. They may need to wear a nicotine patch. Implementation. Nursing care for patient with CVI is focused on improving tissue perfusion and preventing tissue damage. Anytime tissues receive inadequate blood supply, the patient will experience severe pain. As a result, pain management until perfusion can be improved is also a primary nursing focus. Promote tissue perfusion, and we've kind of already gone over this, but the more you hear it, I really want you to focus when you're studying is look at the interventions that the nurse does, because we assess and we plan our care and then we implement, and we have to intervene. So PVD impairs blood flow through the capillary bed, resulting in inadequate oxygen delivery and impaired metabolic waste removal. Cellular function is negatively impacted, resulting in pain and impaired healing. Interventions to promote tissue perfusion are: assess lower extremities, including peripheral pulses, pain, color, temperature, and capillary refill every 4 hours or more as needed. If pulses are difficult to palpate, a Doppler device can locate the peripheral pulses, mark the position with a marker for subsequent assessment, so you can go back and know where you found it with the Doppler. Elevate extremity to promote venous return from the extremity, increasing circulation and relieving pain. Promote regular exercise. Exercise promotes the development of collateral circulation to ischemic tissues and slows the process of atherosclerosis. Maintain extremity temperature by using lightweight blankets, socks, and slippers to promote arterial flow and reduce the vasospasms. And then vasospasms can be really painful. I lost my place. Instruct the patient to avoid electric heating pads or hot water bottles because they can get a burn risk. And again, make sure that they have socks and slippers on too. You don't want them to bump their toe and get a sore or anything like that on their toe. Don't cross their legs or use knee pillows that can compress the blood flow, because knee pillows, if they're under the knee, then the foot's still hanging down. Okay. Managing pain. Pain of PVD is due to tissue ischemia. The qualities of PVD pain are cramping that occurs during activity, while rest resolves pain early in the process. As the PVD worsens, pain occurs even at rest. Interventions for promoting pain include maintain lower extremity temperature, warm legs promote vasodilation, improving arterial blood flow, but be careful with heating pads because they can burn the skin and cause open wounds. Instruct patient in pain relief and stress management techniques such as relaxation, meditation, and guided imagery. Stress and pain are interrelated and cyclic. Increased pain increases stress, leading to vasoconstriction, which triggers more pain. Use a standard pain scale to evaluate subjective experience and to determine effective pain relief interventions. And so, you always want to assess the pain. Is it getting worse? If it's getting worse, the PVD is getting worse. Assess their positioning, assess their activity level, and assess blood flow by looking at the skin. Is the color continuing to change? Is it becoming more cool to touch or hot to touch or more swollen, more shiny, more rubor? You just need to, and you need to report these things. Promote skin integrity. Peripheral vascular disease increases the risk for skin breakdown due to impairment of oxygen and nutrient delivery. Dry, scaly skin and pruritus lead to skin injury during scratching. As the pruritus gets worse, your skin itches more and you're going to scratch it. As healing is impaired, ulceration and infections are adverse sequels. To promote skin integrity, the nurse will promote and provide skin care with the goal of keeping the skin clean and subtle or dry. Apply moisturizing cream on scaly areas to support intact skin, reducing bacterial invasion. Because again, with the open wounds, we have germs on our skin. It can get in the wound can get infected, get in our bloodstream, and lead to sepsis and lead to death. Apply a bed cradle to avoid pressure on the legs. And this is a piece of equipment that you put over the patient and you lay the blanket over top of it so the blanket's not directly touching the patient. You don't see bed cradles used a whole lot. We used to use them all the time. Provide a pressure reducing surface such as an egg crate mattress. And they don't really use egg crate mattresses as often anymore as they do these specialized airflow mattresses that most of the beds in the hospital have now. Use a flotation pad, sheepskin. We don't really use sheepskin anymore either. Heel protectors or those heel boots, but you still need to assess the skin with the boots on. And to reduce the shearing force of the skin against the linens, you want to keep the bed linens straight, neat, keep them unwrinkled, keep the patient turned and position their feet and legs appropriately using pillows to elevate to help relieve. Encourage activity, promote exercise as tolerated unless contraindicated. Stress the importance of a balanced rest between rest and activity. Gradual increase in walking supports collateral circulatory development and improves self-efficacy and well-being. Instruct and encourage active range of motion and position change. These activities reduce extended pressure on specific sites and prevent muscle atrophy and joint contractures while reducing tissue ischemia. Provide activity assistance when needed, as severe claudication can limit activities. Introduce diversions when bed rest is prescribed to relieve boredom and reduce stress, because nobody wants to be on bed rest all the time. We want to get up and move around. Evaluation. The patient provides a return demonstration of proper position of the affected extremity. The patient begins a smoking cessation program. The patient verbalizes proper wound care techniques to the nurse. The patient verbalizes signs and symptoms of infection prior to discharge. And I'd like to read the rest of the evaluation. There's a good paragraph here at the end of this exemplar. Peripheral vascular disease is a slow healing chronic condition that may require years of therapy. It does happen over time. Patients are rarely successful at implementing all the beneficial lifestyle changes immediately. Therefore, the nurse can continue to encourage the patient to implement all the changes required for healing, including using proper skin and wound care techniques, implementing dietary changes, participating in regular physical activity, taking medications as prescribed, and using compression and elevation techniques. Because of the length of therapy required, the nurse should provide emotional support and encouragement for the patient to continue making positive changes, because as you become more debilitated and lose your ability to have mobility, you're going to become more and more emotionally affected by this. The nurse should document the patient's progress and share this progress with the patient, because this helps encourage the individual to maintain the therapeutic regimen that's been developed. If the patient is following all recommendations and healing still has not occurred, the nurse should advocate for further evaluation of the treatment plan. And unfortunately, with PVD, you may not see a healing as the disease process worsens of what might be causing the peripheral disease. There may be no cure for this, but some people do get better with this if they will follow the treatment regimen.